Insulin is lowering glucose, insulin has got anti-inflammatory effect, insulin has got anti-lipolytic effect, anti-apoptotic effect. So to get all of those things which insulin gives you, if you combine these three, metformin, pioglitazone and a GLP-1, you get all those benefits. And with this, he targeted an HbA1c of less than 6%, and look what happens. The sequential therapy did not do bad. Over a period of 2 years, they maintained an HbA1c of 6.5, with the people who got metformin, pio, and a GLP-1 receptor agonist, they maintained an HbA1c of 5.95, which was statistically quite significant. You will say it was only 2 years. They presented the 6-year data. This is only an abstract. I have not come across this paper. Here they say that if you continue with metformin, pioglitazone, and GLP-1 over 6-year period, this is a randomized controlled trial. For the first 2 years, the next 4 years was observation, and you still maintain the reduction in HbA1c. So here's the proof of concept that triple therapy, metformin, pioglitazone, and a GLP-1 receptor agonist. Why this combination we can discuss in question hour time. Is there any other combination you can use? Yes, you can use dual triple combination with basal insulin. Suppose somebody has got high sugars, HbA1c of 9.5, fasting is 250, 300. Dr. Subir Ray, my colleague, and I, we did a small study of a small number of patients, 64 odd patients. If you see the data, I think you can't see it, it's not showing very well. When they presented, they all had an HbA1c, the average HbA1c was 11.8%. Most of them had fasting glucose more than 250. So what we gave them was metformin, GLP-1. We heard a lot about GLP-1. Just by a show of hand, how many of you have more than 10 patients for 6 months on a GLP-1? In this room? 1, 2, 3. Tera to hoga yaar. Okay. So we talk a lot about GLP-1 in our country, yes, but most of our patients can't afford it. So what we used was metformin, DPP-4, and pioglitazone, and we gave them basal insulin, all of them. And if you see how nicely the HbA1c comes down and is maintained over 6 months. Why does this happen? Because when you use these combinations, metformin, pio, GLP-1, metformin, vildagliptin, you are improving the beta cell function. Remember, the holy grail as to why diabetes deteriorates over time is continuing failure of your beta cells. It's not increasing insulin resistance. Insulin resistance is at its peak by the time diabetes is being diagnosed. And you all know that there's an inexorable decline, and that is because of continuous loss of beta cell function. And all this combination therapy try to prevent that. So what are the pros and cons of initial combination therapy? Dr. Mukherjee, you're saying combination therapy, but none of the guidelines advise combination therapy. Why? Because the guidelines are behind. The guidelines will change. In another 3 to 5 years' time, you will be using combination therapy. Having said that, in India, we do use combination therapy quite often. But I think we choose the wrong combination. That's the purpose. If you see, this is the latest ADA ESD guideline. The last guideline they had was 2018, which they updated up to 2019. You see the ADA standards of care. They keep coming out every year. The 2024 guidelines, the standards of care has come out. But the ESD ADA guidelines, this is the last one. This was modified slightly in 2019. And they still say that stepwise therapy is supported by clinical trials. Grudgingly, they have now begun to, before 2018, combination therapy was not there in the ADA ESD guidelines. In 2018, the combination therapy comes in, and what do they say? Look at all the 3 points on the right-hand side. They're not endorsing it wholeheartedly, but they're saying there's some support, there's greater initial reduction of HbA1c based on the EDICT study which Defonso did, and they've grudgingly accepted that if HbA1c is more than 1.5% of your target, whatever your target is, 6.56, 7.57, depending on your patient's profile, you should be thinking of the combination therapy. So which combinations to use? Choose a combination which takes care of all the pathological defects. These are all the drugs available to you. Amylin mimetics, bilateral sequestrin, dopamine 2 agonists not available to us. So amongst all these, how will you approach? So I'm just synthesizing. I'll take 2 minutes extra, sir. I'm going to synthesize what you heard. You heard Pamela saying that type 2 diabetes, there are 5 subtypes. Fair enough. Any type 2 diabetic patient comes to you in your clinic, just think about 2 subtypes. All the SID, SAD, MOD, MAD, HAD, LAD that you heard, all that doesn't make much sense in the clinic. What makes sense is LADA. If it's LADA, your oral hypoglycemia is not going to work, and if it's a MODI. If these 2 are not there, next you decide your HbA1c target. It will not be the same for everybody. If somebody has got underlying cardiovascular disease, you will think about 7, 7.5. Elderly patient, low lifespan, you will think about 8.5, 9. And a young man like me who comes to you with type 2 diabetes, you would think of 6%, won't you? So Once you have done that, you look for any specific indication or contraindication. If somebody has got CKD, heart failure, atherosclerotic cardiovascular disease, high risk for these, you have to think of an SGLT2, GLP-1. But 80 to 85% patients seen by most of you, not the people in the front row, they will be seeing the more complicated patients, but most of you in your general practice will be seeing people who do not have heart failure, do not have CKD, do not have atherosclerotic cardiovascular disease. So for them, what would you do? If cost is an issue, you think about metformin, sulfonylurea, pioglitazone, human insulin, and now I can on the same breath add a DPP-4 and SGLT2 in India because they are also quite cheap. But if cost is not an issue, you will think about combinations. And the various combinations are there. I mean, I can't take you through this. I mean, this is a chapter we wrote in Professor Sadiko's textbook of diabetes. You can get hold of that book, and I will just take you through it in my last slide. So are the guidelines beginning to change, thinking of combination therapy? Yes, they are beginning to change. And the ADA-ESD guideline, as I said, grudgingly have accepted that if HbA1c is more than 1.5% above the target, think of combination therapy. So we know that early achievement of tight glycemic control protects beta cell function. We know that early achievement of tight glycemic control reduces macrovascular condition. We know there's evidence for individual anti-diabetic medications available. So what is the problem in starting combination therapy?